So thank you, Joanna, very much for the introductions and for the opportunities to present here today. I think in years to come, I'll think back and think, what are the achievements of this fellowship, Marie Curie Fellowship, and I think, I was invited to give an AIHI seminar, so yes, thank you. So before I start with my talk, I'd just like to acknowledge the fellowship program. This is the Marie Curie program. It's a fantastic initiative. I'm definitely a fan, as you can imagine. It's for Europeans that want to spend time and opportunity to research outside of Europe, but it's also for non-Europeans to spend some time in European institutions. So if you want to think about it, the deadlines is usually in September. My project is to study resilience, mindfulness, and medication safety with electronic systems. It's a collaboration with Joanna here at the Institute and Professor Brani Dean Franklin at the UCL School of Pharmacy. What I'll talk about today is about mindfulness and medication safety with electronic systems in oncology. But before I get to tell you about this, I think there's a tradition in AIHI seminars that the visitors tell you a little bit about their backgrounds, where they're coming from, and it's usually done with some pictures, some nice pictures. So I got some nice pictures. So I'm originally from Italy, from Rome, and this is St. Peter's and the bridge. This is the bridge I crossed every day to go to school. My family home is just around the corner from this. And so in Rome, you're just surrounded by all that Baroque architecture and fountains and churches, and you just have to look up, So it's just, I like to think that some of these I bring with me when I do research, and qualitative research. But in 2001, I moved to the UK to do a Master in Information Systems and Technology and a PhD in Human-Computer Interaction. And so in a sense, in terms of my research, the UK is where I'm coming from. And I have currently two affiliations. So I'm coming from the University of Leeds, but also the fellowship is with UCL School of Pharmacy. And what can I tell you about UCL? I mean, the University College London is in the league tables for universities is in the top 10 internationally. Some league tables even goes, above Oxford and Cambridge. So you probably know everything about UCL. This School of Pharmacy is in central London, and they have some fantastic coffee shops, and some I can really recommend, so it's always a pleasure to be there. I thought I'd just spend another minute just to tell you a bit about Leeds, because Leeds maybe is less well known internationally. It's one of the biggest cities in England. I think it's the second or third city after London, and it's about halfway between London and Edinburgh, about 2.5 hours. It's on the border with the Yorkshire Dales National Park, and that's where the Bronte sisters set their books, so it's pretty romantic stuff. And this is my way to work on a wintry day a few years ago. On a snowy day, I was cycling to work. So this is the campus. This is the University of Leeds campus, and this is the School of Healthcare. So if or when I go back to Leeds in 2021, which is just around the corner in a sense, I'll go back to the business school, because I will collaborate with the School of Healthcare, because my research is interdisciplinary, and it's health services research, but it's also research about information management in organizations. So it's qualitative research. I study people's work. I take pictures of them, drawings. I study their information needs and how we can design technology to meet those needs. I believe, though, I'm a system thinker. I believe that technologies are, we should understand them as socio-technical systems. And really, if we want to understand people's information needs, we have to understand the activities. So what I do is I map patients' trajectories. I model work as done in same activities in different practices. For the last study I did in Leeds before coming to Australia, I followed the drugs in a hospital, in Leeds Hospital, and looked at how technology supported the supply and use of that and drug medications around the entire hospital. So the social technical system I'm going to tell you about today is the Westmead Children's Hospitals, the oncology unit. And actually, I must say that the head of the unit, Dr. Luciano Dalla Pozza, just joined us now. So thank you, Luciano, for being here. Thank you for welcoming in your unit. So as probably almost everybody here knows, the hospital has implemented a few years ago an electronic medication management system that is supporting prescribing, reviewing, administration of medications. It's a Cerner system. This is what it looks like a little bit. This is a test patient, so it might not be a realistic picture of a screen, but it's just to give you a sense. So as part of this this implementation of this system, the system has a module or a functionality that's called Power Plan that enables to link the different medication orders. So a focus on this functionality would look a little bit like this. This is used for chemotherapy prescribing in the hospital now, but it's not designed specifically for chemotherapy. So it's not specifically a chemotherapy system. So the functionality, Power Plan functionality, is used in the hospital also for other clinical needs. But it's also maybe important to say that in this system, you can add orders. Anything that can be ordered can be added in there. So tests, for example, are orderable. So you can link tests and medications into this Power Plan. I'm focusing on the medication, and we talk about medication safety, but really in the system, it's more than electronic medication management system because you can order other things. They're all orderables. Just very briefly, I'm not going to say much about the literature on this or the evidence, but I have a sense that there is very little that is written about the use of chemotherapy systems in hospital. This is a recent systematic review. They've only found 27 papers that could be included in the study. 18 were about user satisfaction and the implementation of the system, and only 3 studies were really about the effect of the system on how it was used in oncology. So I think it's an area that, because these chemotherapy systems are really hard to implement, difficult to implement safely, and so the implementations have been slow internationally. They're more used in the US, but less frequently used in other countries. So we don't really know much about what happens when you introduce a chemotherapy system in a hospital. So clinical work is a social-technical system. You introduce a new technology in your social-technical system, you change the social-technical system, you change the system, you change your work practices, and this is how you also introduce, as you produce medication safety or generate medication safety, because you're changing practices. But when you're changing practices, you might also create new mechanisms for errors, new risks, and also you might change those practices that have to do with what is known as collective mindfulness. So those practices that also produce safety. And so we want to know, with this research, we wanted to know if introducing this system in the oncology unit, would it change the collective mindfulness in this unit? And so here I'm going to open a parenthesis, talk a little bit about theory. It's just going to a few minutes just to clarify a few concepts. And the postcards that you may have picked up at the entrance might be useful because it might give you some definitions. So the theory of collective mindfulness claims that in high reliability organizations such as Navy aircraft carriers or firefighters, the people have a collective capacity to anticipate, adapt, and recover from unexpected events. So it's, in a sense, it's a state of mind of the entire organization that is made of 5 interrelated dimensions. The definitions are on the cards, but they are preoccupation with failures, reluctance to simplify interpretations, sensitivity to operations, commitment to resilience, and deference to expertise. And for this study in particular, I think the one that is most relevant is the sensitivity to operations and preoccupation with, the one at the top, reluctance to simplify, preoccupation with failure, the one about anticipating the unexpected. But you really have to look at the 5 altogether. They are, in a sense, it's a theory of organizational learning that as people face the unexpected, adapt and learn how to resolve the incident, maybe prevent causing harm, this will become learning. It will be learned. The group will learn about this experience, and this will enrich their repertoire in a sense of solutions for the next time. But this capacity to adapt, to make sense of the environment and for resilience is also it's only one way of organizing for safety. Actually, going back to models of safety, the high reliability, the one about managing risk, that I would say the firefighting is what more characterizing it, because there are procedures in this model of safety. Of course, there are procedures, and the learning is for the group, but it's the procedures can never cover all the events. The other model of safety, the way we can organize safety, is ultra safe, and that's what we experience when we take an airplane. Or it's, aviation and the nuclear industry are typical examples of this model of ultra safety. And when you organize an industry in this slide, you use rigid procedures, standardization, optimization of workflow, work settings. You can imagine the cockpit, how it's designed and optimized. And there is the main strategy is to avoid exposing frontline actors to unnecessary risks. And this is what we might call the plan A. So you ground all aircrafts if there is a volcano exploding or if there is a fire alarm in the somewhere in the airport. I'll come back to this plan A, which is refused to do unless ideal conditions. And then the third model of safety is the ultra adaptive, which is the basically it's when you climb the Himalaya, you really, for safety, you have to rely on your expertise and your experience. It's about personal resilience. And I was looking for, icons to put on these slides. I was looking for climbing the Himalaya and firefighting. But actually, I think if we stay with the analogy of the air transports, that gives you a better idea of the scale of accidents that happen with this, in these three contexts. So you have aviation, and then public transports and cars, we know, very accident prone, and then bicycles, really accident prone. And they're really, with bicycle, you really rely on your experience as a cyclist. So, coming to the study, I know I have to go maybe a bit more quickly. So the question is, how does collective mindfulness manifest in this setting, and how is it supported by the system? I'm not going to tell you much about the method because I haven't got time, but it's a quality study. It was based on analysis of incidents that occurred in the oncology unit after the implementation, and 20 interviews with clinicians in the unit, and the doctors, nurses, pharmacists, and the power plant team. And the only thing I'd say is that the interviews were kind of ethnographic, so very loosely structured, very much about understanding people's work and what they need in their work. So what did I find? This is such, it's a limited scope. The study is a limited scope, but very rich findings. And I had to make a tough choice today, what I was going to present to you today. So I'm going to try to limit it to 4 aspects that I think are interesting and important. So first I'm going to tell you about this, a little bit about the context. So it's the interdependencies that characterize pediatric oncology, and the nature of the prescription that as technology designers, that we computerize. And then I'm going to tell you there is strategies that clinicians use to manage these interdependencies, and how the electronic prescription supports these risk management strategies or not. So here I'm just thinking chemotherapy administration, chemotherapy treatments. I'm not thinking diagnosis or surgery or all the other aspects of oncology. Even if you just think chemotherapy, the context is really rich of complexities and interdependencies. So you have to involve the intensive care unit, you have to the general anesthetics, and all sorts of other hospital services. So these are, in a sense, interdependencies to do with the organization, with the workflow. And then there are interdependencies related to the protocol, the actual treatment. So in pediatric oncology, it's protocol mandated care. So every patient is assigned a protocol, and the protocol will tell you which drugs you have to give, at what intervals. The treatment will all be organized in cycles that may last for a couple of years. So you'll have an admission, and then some outpatient visits, and then another admission, etc. And then you monitor. You give the drugs. You monitor for toxicity, and you have to wait for the patient to recover. So this is what a protocol looks like. You have different medications and the different dose rules for the dose. It might also look a little bit like this. This is what they call a roadmap of a protocol, and you have more like the weeks, week 1, week 2, week 3, week 4, etc. for the different drugs. So when you look at a prescription, like you're prescribing a dose, so that dose will be related to previous doses and future doses, of course, in this protocol. But the actual dose, which can be one or more drugs, will have some pre-medication, that may be fluids, and will have some medications after the dose, that antidotes, and this must be given at exactly specific times after you've given the dose, because otherwise either you kill the patient or you don't kill the cancer. So then you will have medications that you have to be concurrent to that dose. So there are some time dependencies within the dose, the administration of the dose prescription. So to me, a chemotherapy prescription doesn't look very much like a normal hospital prescription where you have like maybe regular doses over a week. It looks much more like a project plan. So this is a picture from Microsoft Project, and you would have tasks, and the tasks have people assigned to them and times, and they're linked, and you have critical paths and things like that. And we know from the literature and also from the incidents that it's quite hard to follow these protocols and also to manage these interdependencies in the protocol. So you have errors like wrong cycle numbers, exceeding cumulative doses, you got delays, wrong dates, and so it's clearly not easy to set up these kind of prescriptions. So just as a summary, I mentioned the hospital workflow-related interdependencies and the protocol-related interdependencies. And of course, these are also related because that's the kind of, when you're trying to follow the protocol, you meet the constraints of the hospital, etc. So you need to manage both for medication safety. And we have a sense that, well, then collective mindfulness with the sensitivity for operations and the preoccupation with failures would fit. You would need collective mindfulness to manage and achieve medication safety. But going through the data, actually, I maybe perhaps was surprised, maybe not. I had to take into account the fact that the data was telling me something different, that it's not just collective mindfulness that is used for safety. There are, in chemotherapy, really, you make a lot of use of the strategies of the ultra-safe. And just as a reminder, it's the optimize the system, you have rigid rules, and you have this plan A of refusing to do unless ideal conditions. So in chemotherapy, you have rigid rules on the content of the prescriptions, which drugs, which intervals. You have rigid rules, so who can act on the prescription, whether you can prescribe or administer. You have this, the plan A. You have the treatment is stopped until the patient recovers, and you have multiple checks along the medication process. You can see yourself on the aircraft and looking downstairs, and you have all these people checking the airplane, So similar thing in chemotherapy, everybody's checking the medication. And the electronic medication management system supports this strategy. In a sense, for example, you make templates that all contain all the drugs that the protocol dictates and all the time dependencies. They're all pre-coded, so people will not forget. Yeah, they're there. You have user profiles, so some people are authorized to prescribe, other people are not. And then you have a workflow management system that automatically routes the prescription to the next person. You have a checkbox that needs to be ticked for the administration to go ahead. So that's the plan A. We're stopping until the patient is ready to receive the drug. And you have multiple checks in the medication process, so the system requires double signatures, for example, from the nurses. So the automation seems to support this ultra-safe model. But, there's always a but. If you use plan A, which is the stop until the patient recovers, you end up having frequent rescheduling, of course. I mean, look at airplanes. We always suffer delays. There is always we shouldn't be surprised. This means that for doctors prescribing, there will always be some uncertainty on when the next treatment will be given. And the scheduling or the rescheduling will have to take into account the hospital's constraints. So general anesthetics is not available on the Sunday, it's only available on a Thursday, or the automation would put your next dose on Christmas Day, that's not a very good day, and etc. And then you schedule everything and you think it's all set for giving the patient dose, and then some other patients with more urgent, the more urgent emergencies come up, so you have to reschedule. So there's collective mindfulness that comes back to the picture. And there's a risk strategy that perhaps we don't pay enough attention to, which is the doctors playing with time or using time to manage risk. Doctor skills consist of playing with time rather than being caught by time, because time reveals the evidence. So the doctors in this unit in my view, they're using 3 different time horizons when they deal with chemotherapy prescriptions. They have a lifelong view. This is about cumulative doses, for example, that will produce risks later in life for the patient, even when it becomes an adult. You have a whole treatment view, so you're prescribing that single dose there, but you have to see how that dose fits in the whole treatment. Which drugs did you give previously? Which drugs will you give later? So the thinking is retrospective and prospective, and you have to have a sense of where you're at any moment in time in this whole treatment. And then you have what I call the here and now, which is the view over the minutiae of the single administration, where you have to know that you have to give fluid before and you have to give the antidote afterwards, and there are some, the time dependencies. And if you don't inform pharmacy in advance, you're not going to have the chemotherapy ready for the day. And then the nurses have to have the go-ahead early in the morning so that they can give it before the day ends. So that's about understanding the specific of the. So at any point, all throughout this, this process, the doctors would have to have a situation awareness, where we are with the treatment, what is the situation with the patient. They would have to have team awareness, do I have to inform the nurses, and organizational awareness. So, can I have a general anesthetics today? How do I get energetic studies? But to this, actually, we also have to add an IT awareness. So there's group learning or collective mindfulness as a learning in the unit of the how the system is used in this setting and the limitation and the constraints of the system. So, for example, you learn that when you have a protocol started and you have a start date, and actually that start date it's not really the start date because it's been delayed, but you can't change it. But that means that when you're planning the dose, the due next. It seems like it's due next week, but if you look at the chemotherapy, it's actually given the due in 2 weeks. So the dates in the system they not necessarily change as you would expect. And similarly for the administration of the dose. If the nurses sign at the time of preparing rather than at the time of the administration, there will be a gap. Now, this gap is usually not that big of a difference, but when you're waiting 24 hours after to do something, then the actual time actually is important. So I'm going to conclude. I don't know if I'm okay. So we're okay. So I'm going to conclude with 3 recommendations for design and 3 lessons for safety science, let's say, 3 attempts to go beyond the specific settings of the oncology unit. So my 3 recommendations for chemotherapy systems are first that either we ensure that there is enough granularity in the modeling of the work as done, you model it to embed it in the system so that you can capture the exact time, so when activities take place. So maybe we add an extra task, which is medicine preparation. Or you find a different way to timestamp activities, like maybe the time of the dose is the time that we scan the patient wristband. Of course, this granularity is better when you design a system. It's easier to match the workflow exactly when you make a system which is specifically a chemotherapy system. If you use a more generic system that has to support all medication workflows, it's much harder to find a kind of a close match between the two. But because in chemotherapy times are so important, there must be a way to capture the exact times, I think. Then there must be different visualizations to support different time horizons. So maybe we go back to Microsoft Project and a different different displays. And I must, again, here, different system enable different views. And the Cerner system doesn't seem to me that supports very well the whole. It supports better the here and now, but it doesn't really support the where you're at in the overall protocol picture. This was an old system from the Netherlands, used in the Netherlands in 2012, and that's a digital version of a digital summary of the roadmap. So clearly, if you make a system that is specific for oncology, you can do these kind of things. And the third one is the ability to easily trace and compute the cumulative effects over a lifetime. This is a bit more challenging for a chemotherapy system, I think. You can build some alerts. You have to do it drug per drug. So for each drug, you have to build an algorithm in the system that calculates the accumulation for that drug, and then it could alert the clinician at the time of prescribing. But because patients change settings, they're treated in different settings, and if you're a child, you grow up, you can be treated in an adult setting after when you become an adult. So maybe this is also maybe more of a requirement for something like my health record, or a kind of a patient record system that is a lifelong record, where we can keep a track of the medications that have, where it's important to see the cumulative effect. There are other requirements we can think of for chemotherapy systems, but these are three that might come through this study. And then, now coming maybe to some lessons, general lessons for safety science. These are more like thoughts for reflections. So one is that it seems that automation pushes towards the ultra-safe risk management strategies, or at least supports the better than, for example, collective mindfulness. But they do so better for the short term than for the whole treatment view, or the longer time period. And then you need collective mindfulness to operate the IT safely, despite the technology embedding the ultra-safe strategies. So you have automation that is supposed to, that is ultra-safe, but then you have collective mindfulness to manage that automation. And so maybe a corollary to this is that with adaptation, then it's essential to stay in protocol. And this is a little bit counterintuitive, because usually we think of protocols as the opposites of adaptation. We say if you want to do patient-centered care, you can't standardize and things. So we see them as opposites. But actually, in chemotherapy, you need adaptation in order to stay on protocol. And I found that actually this was something said in the 90s, but medical sociologists who were studying also the use of chemotherapy of oncology protocols, that clinicians' active, not mindless support is crucial to maintain the protocol's trajectory on course. So this is true also when you make the protocol electronic. And the third one, I think it's very difficult to operate as ultra-safe when your unit is not self-sufficient. So you're not like a nuclear power plant or a power plant, which are also open systems, because of course the energy comes in and out, sources, etc. You can think of them and design them and optimize them as closed systems. While if you have a unit, you want to plan and optimize it as an ultra-safe system, but then it's embedded in a bigger system that it's not organized with ultra-safe. There are challenges. What's the answer to this challenge? You can't really make the entire hospital ultra-safe, because there are aspects of patient care you wouldn't want to be organized. So I've organized as ultra-safe, like chronic care, for example. And it would be very expensive to make an oncology unit self-sufficient. We would have to have your own imaging services. But I was thinking this morning coming here that maybe we could think of some kind of, the fast track boarding lane, that we could have, the hospital could organize some fast track lanes for cancer kids, so that it's less challenging to schedule your next dose, because you have some dedicated slots for that. I don't know, but I leave this as the question for the audience. This is very much work in progress, so any question or suggestions or corrections are very much welcome. Thank you.